Good evening. I'm the last talk of the day, and it's been a long day, a great day. It's a pleasure to be here. I'd like to thank the organisers for asking me to do this talk last night and putting me up here after two great speakers and excellent knowledge base in this area. I've got to say this isn't my area of expertise, so my team can thank me for not throwing it at one of them last night. And having worked in elite sport for most of my career, I can only recall treating two of these Achilles ruptures in elite athletes in the UK, and I personally haven't treated any Achilles tendon ruptures here, so I'll declare my knowledge base up front. The one thing I'd say about it is it always amazes me that these actually get better, because when you look at the pathology, it's just horrendous, and it is amazing that people actually get better. So I'm going to approach this a bit more from a sports medicine perspective. And the first thing I'd say is, what do we mean when we talk about return to play? Because it's completely different when we're talking about a recreational athlete from a professional athlete, and Professor Carlson alluded to the pretty ordinary return to same level, and I'll mention that again coming up in a second. But just to illustrate the difference, I've got a couple of pictures to show you. So return to play for this athlete was at 5 weeks. Okay, post repair of a Achilles tendon rupture, and you can see that it's not a full return to play because he's still wearing a plaster. Okay, but if you just go backwards and you look at the date, and this is one of the things that we've got to take into consideration in sports medicine, is that there's times where you've just got to do what you've got to do, and getting that last surf in for for 1999 was clearly important. So it can be done, all right? That's just the cast. By comparison, if I can get this going, no I can't, hang on. This is your genuine elite athletes. And this is just amazing. I use this, a lot of you will have seen this, this little video before, so this is ultra high speed, high frequency frames again. These are two Olympic level athletes about 3 weeks before the Athens Olympics. One of these guys goes on to win an Olympic gold medal, and the other guy doesn't compete, pulls out with one of multiple injuries. One of them's been injured over and over and over again, including Achilles, peroneal tendons, tib post, and back and hip and knees. Okay, and I'll just draw you. I mean, what I'm really interested in is just the. Have I just stopped that? I did just stop that. That was remarkable. I'll try not to take too much time. But I'm just interested, like this guy, and I won't use the pointer again, just the torque that's going through the Achilles. And when you're talking about trying to get someone back to return to play at an elite level, that's what we're talking about. We're talking about incredible forces here. And you can see when he plants this foot, the actual rotation and everything, I mean, the forces going through there must just be amazing. And so to actually get back to that level of sport is extremely difficult. Just out of interest, it's the guy on the right that wins the Olympic gold, and the other one is constantly injured, which is a little bit counterintuitive when you look at that footage. So this is from Gordon Matheson's team over in Stanford, and I think this is actually quite nice. This came out a couple of years ago, because what this does is actually focus on this is a way of looking at a return to play. Okay, so I'm stepping away a little bit from just the Achilles, but just looking at return to play. Because what happens most of the time when we sit here and talk about return to play, we're sitting up here talking about this. We're talking about their operative recovery, their immediate return, their strength tests, their functional tests, and all of that. But the reality is when we're dealing with elite athletes and the public as well, there's a whole lot of these other factors involved as well. So these are sport risk modifiers, so it depends on what the type of sport is. You may be able to go back to surfing a lot easier than gymnastics. Dominance, ability to protect it, and then all of these things. So, you know, the 31st of December 1999 would fit into one of these decision modifiers as to when you will return to play. And I think it's important to remember when we're talking about to return to play that it's more than just the medical elements that will be affecting us. And so that's just my push from a sports medicine perspective. The other thing that's interesting in the very quick flick through one book that I did in preparation for this talk, as we move away essentially from patient demographics, which we can articulate and scientifically review very carefully, as we move away from that, the evidence base gets less and less. So as we get into these decision modifiers and sports risk modifiers, which form a critical part of our decision-making process, there's really hardly any evidence at all, and that's an important thing to keep in mind. So this has already been talked about, so I won't redo this, but up to 60% might return to the same level of sport and surgery, but even less than that has been reported in conservative approaches, and other authors have found no difference in outcome between surgery and conservative, as has already been talked about. But it is, a remarkably, significant impact on someone's career or sporting ability. Return to play time. Well, we would expect between 5 and 6 months, but it's interesting the work from Nick Mafuli and Nick Van Dyke and others as well. Functional bracing, you can knock that down to 3.5 months if you're really aggressive. And we've seen that, early treatment with functional bracing will actually speed up the early part of your recovery. But the point that's always made, and it's got to be reiterated all the time, is that this is really in motivated, reliable and professional patients. And when I say professional, I don't mean doctors or nurses or anything, or professional footballers or anything. I mean actually a professional approach to their rehabilitation. I think if you've got those sort of characteristics in your patient, then you've got a much better chance of getting a rapid return. Considerations, we're all aware of these things: inflammatory, reparative and remodelling phases, and obviously it continues well on past 20 weeks. It's quite nice because in the book of Van Dyke, that a lot of the authors here I'm sure have all contributed to, they break the process of return to play down into 4 levels. And I just highlight that this really takes into account a lot of medical considerations, but not the model of Gordon Matheson and his team. So it's this is a much more medicalised model. But it's nice because they've called it level 1 to 4, which makes it nice and easy. And I will just quickly go through these because I think it is a really nice model to keep in mind. So level 1, the goal is, no matter whether you've had an operation or no operation, the goal is to return to normal walking. And that's really about that initial phase of healing of the tissue, a gradual symptom-tolerated static movements to dynamic movements to concentric to eccentric. And we're doing that as tolerated. At the end of that phase, we'll accept 25% difference in strength and functional measures, but we would hope that pain and swelling, which are 2 of the key indicators of progress through a pathway like this, are absent 48 hours after doing any activity. And we'll monitor that as we go through each phase. That's an 8 to 12 week phase, so 2 to 3 months in that to get back to normal walking. Level 2 is to get back to running, and this is defined as jogging, so light running. The processes that we're interested in here are the range of motion, starting to increase the strength and the force that can be tolerated, technical skills, endurance, CV, in non-loading activities. At the end of this, we'd accept a 12% deficit between the left and right side. And when as we progress through this, we would expect the pain and swelling after any exercise to be back to normal within 24 hours. So you can see we've reduced it from 48 hours to 24 hours, so we're starting to see a reduction in the pain and swelling. And that's a 4 to 6 week phase. The third level is to return to non-contact sport. Here we're looking at really progressing the speed, the strength, the uneven ground sprinting, and we want the functionally to be the same as the contralateral side at this point. We should have no swelling anymore, but we would expect or allow for the pain to be there after exercise or after stressing it. We'd expect some pain, but we'd want that to be gone within 24 hours. And this is a 4 to 6 week phase. I think this is often, to me, and in my experience certainly with the elite athletes, this has always been one where we've been a little more hesitant and slow. And the level 4, the final level, is returning to contact sport, where we're doing full functional and sport-specific training. Obviously, at this point, you start to get very psychological. You've got to have taken all these steps and have the athlete's got to have the confidence to be able to move forward. And at this point, you would expect still some pain, perhaps, when they're doing this, but by 24 hours post-exercise, they should be pain-free, and that should be reducing over time. And that's a 4 to 6 weeks progress. Now, based on that, you can get out to your 5 to 6 month protocol. But then again, it will depend on all of those factors that Gordon Matheson's group have highlighted. When you're getting into this 4th phase of return to play, that's when you'll start to be taking into account all of those other factors that might be influencing when you're going to be coming back. So, very brief talk. just to summarise, I think there's multiple considerations when you're talking about return to play. It's not as simple as just the medical factors involved, and it is difficult to study that. The further we move from the injury, the level of evidence as to which factors will affect your return to play become less controlled and less well known. The return to play's got to be graduated, it's got to be well controlled, and the more motivated and focused your patient or your athlete, then the likely better outcomes. And pain and swelling during all phases of your rehabilitation are the key elements that are worth looking at. Thanks.